Yeah, g'day, Brian Concan. I've got a couple of quick questions. You mentioned the computers were being privatised and they're backtracking on that. Has that got anything to do with the Medicare offices? Someone told me that the Medicare offices are all going to be privatised. Is that part of the computers in them? And as well, when the late, great Gough Whitlam privatised Medicare, I think the levy was at 1.25% or something. That slowly disintegrated. I think it went up once. Is there any way that levy could pay for the Medicare costs if it was raised? And what would it have to be raised? And is there anything you can tell me a history of that levy and why it went? How come they're not talking about raising the levy?
I don't know any more about the privatisation of the computers than you do. It became a political issue. I do believe the Medicare computer is badly out of date and needs to be improved, because John Nearhouse was at the forefront of computer monitoring of payments in the 1990s and was working with the Health Insurance Commission, which got the Auditor General's report, which dated 1992, which said the Medicare computer is not following things up properly and should be better organised. The Health Insurance Commission was then abolished by John Howard, so of course the policeman role which was put into the Health Insurance Commission when Medibank was set up by Whitlam was in fact emasculated and abolished by John Howard, and effectively it just pays. I don't believe it controls fraud very well. Fraud's been a huge problem in the US and is something of a problem here, and overcharging is a problem. I mean, if you've got a cow, you milk it, you know what I mean? I'm afraid there are people who do these things and we have to face that reality. So it probably does need a new computer. The last thing you want to do is privatise it, because if you look at the percentage of GDP spent on private health as opposed to publicly supplied health across all the countries in the OECD, the ones that have more, the more private they have, the higher percentage of GDP they pay in health costs, pretty much across the board, because the private sector simply can't control costs. The only way to control costs, and any economist will tell you, if you have a single provider, you can control costs. If you've got competing providers trying to please people, you can't control costs. That's the reality. So a new computer is needed, but not just a private one that says beauty, will pay everybody as cheaply as possible and pass the costs on, which is what a business would do. That would be in their interest. In terms of the Medicare offices, I don't know. This is the realm of rumour at the times of elections, I guess. But I mean, they've privatised the post office. I believe they're trying to give us much. There's a dogma that government has to be small, and so they're giving away every office they possibly can. And I think that's an ideological trend, I think. The levy is just another tax to fund it. It doesn't have to come from the levy any more than it has to come from anything else, actually. So the levy was brought in as a sort of token to tell you that there was Medicare. It never covered Medicare, and of course it hasn't been raised, and it now covers Medicare less because the percentage of GDP spent on health is rising. Hasn't risen to the American levels yet, but the more it's privatised, the more it will be raised. It might be mentioned that America has, 300 million people, of which 100 have almost no insurance, and the reforms that Obama got in were effectively just locked in the private health insurance, so it didn't actually solve the problem because he was defeated at a parliamentary level over there. But yeah.
If we've got another great leader like Gough, is there any way they could raise the levy to substantiate the cost of healthcare? You think they?
The cheapest healthcare we could ever get would be to have a universal system where there was no private health insurance. It simply paid the doctors. I believe they have to pay them a living wage. I reckon it was set at 85%. I think that's reasonable. I mean, I'm a doctor, I would say that. But once you start arguing, you know, they'll do it on 70% or whatever, you know, you won't get universal service. The doctors have to be happy in that service, and then the ones that over-service the system can deal with, and so it should. But this idea that it's all payment by how sick you are, not by how rich you are, not by how sick you are, is a recipe for disaster, really. And I mean, a levy is just another way of saying the tax. It doesn't matter how the tax is collected. I don't believe, but it should be a universal service. And if they raise the Medicare rebate to, let's say, 85% of the common fee and put in a decent computer system, the whole private health insurance industry would collapse. And the private hospitals would compete directly with the public hospitals, which in some cases they'd be quite able to do if they actually put their mind to it, because they're doing standard things. Like if they do all gallbladders and all hernias and all simple operations, they know relatively healthy people are coming in, they're having a simple procedure and they're going home. Whereas the public hospital system has to deal with anything that comes through the door or through the helicopter, you know what I mean? They're dealing with everything. So they're not as efficient per day, but they are more flexible. So the private hospitals probably could compete if the Medicare rebate was at a reasonable level.
Yes, Jeff Lee, I've got one question for both speakers, for Dr. Arthur Chesterfield-Evans, who I was so nervous about your election campaign that I took up smoking again, hoping that you would beat that Liberal Party bake over there in North Sydney, knowing that you're a member of PUP and the anti-smoking campaign. I'll try and give up again. That's just the intro, but I've got a couple of simple questions. One relates to over-servicing both by doctors and by patients, because in the long run, somehow we're going to have to pay for Medicare. In the future, it's just going to keep escalating as the population gets older, and as you know, and as services become more expensive. On the over-servicing thing, can you give us your opinion on the question of the high-tech cost of technology? Is it always necessary versus that? That's a question on the doctor's side, and the constant referrals from GPs to specialists and all that sort of thing. Okay, is it making people live longer? Yes, but is it always necessary? And obviously you're a supporter of preventive medicine, so you could probably throw in a comparison there. But from the patient's point of view, even as a low income earner, I think if you had $2 or $3 to pay a doctor to go and see a GP with 85% off billing now, it might stop these basically, dare I say it, junkies who just go in every week to get more pills off the GP. You know, there just seems to me some people who just love going to GPs even for a chat, you know, and especially older people who live alone. That's my question to you. And my question to James on the insurance thing. The latest issue of Sparks, for rank and file public transport workers, has got this horrendous story of a railway worker at Town Hall Station who fell over a bucket and nearly finished up on the lines and nearly broke his neck and had a serious injury and was in hospital, and his supervisor came in the next day and said, I've seen the video, you know, you're lucky you're not dead. And then when he recuperated enough, he tried to get a copy of the video and they wouldn't show it to him. And with his union rep and his lawyer, he eventually saw a copy of it, but they redubbed it over and totally destroyed it. And then he had a private investigator come in they only took him back on work on short shifts and all this sort of thing on light duties. But it's absolutely scandalous. It should be referred to ICAC, all the manipulation that's going on. And it reminds me of the Neville Rand period when they brought in the table of maims. You get $5,000 for a finger, you get $5,000 for a toe, you get $10,000 for a foot, and $15,000 for a hand, and all that sort of thing. How much is a worker worth?
There were 3 questions in that.
Yeah, from the consumer end and from the doctor's end.
Yeah, right. Well, bullying's alive and well. The insurance companies spend a lot of money on investigators, and they now have rehabilitation professionals who do case conferences with the doctor and say, doctor, I think he can go back to work, you know. And if you say you can't, oh, you don't understand modern rehab, doctor, you old fuddy-duddy. Either you're a fraudster or you're a fuddy-duddy, and they can go back to work because, you know, that's really what makes the best thing for people's health. So you get bullied now, and the rehab people sometimes help the patient and sometimes help the insurers. Bullying is absolutely intrinsic in this system, right? That's the first thing I'd say. Second thing, as far as the table of MAMES is concerned, it was interesting some time ago. I remember that there was a rugby league footballer who got photographed in the shower wearing in the nick, and was very upset about this and got awarded damages, which turned out to be something like 7 times more than if he'd had the damn thing chopped off in the table of MAMES, which seemed to me to say something about society's values. But anyway, since the table of MAMES has come, they now have a thing called the AMA guidelines, which are a very, very pernicious thing. AMA guidelines are from the American Medical Association guidelines, and their full title is the AMA guidelines for the assessment of permanent impairment. Now, the first thing wrong with that is that permanent impairment's quite a difficult thing. An impairment's one thing. The question whether it's an impairment or disability. If I have poor vision, I have an impairment. If I wear glasses, I have no disability. Get it? So there's a difference between impairment and a disability. And in terms of if you, for example, are a paraplegic and you happen to be a mathematician, you can sit there and do your mathematics in your wheelchair. If you're a labourer, you're absolutely unemployable, right? So the impairment and the disability don't correlate. That's the first point. The second point is that the AMA guidelines were bullied out of the AMA by American insurers and basically are designed to measure your impairment without any regard to pain, because you can't measure pain. You can measure everything else, but you can't measure pain. So, of course, the guidelines are designed that all doctors examining the patient will come to the same percentage of disability, right? Now, so the doctors do that and come up with a number, right? Depend on certain definitions that the AMA have put there. But since the main thing that stops people working is pain, effectively the guidelines are absolute rubbish. You can be 1% impaired and 100% unemployable, 100% unable to work, and that is routinely the case. So it suits the insurers and the people who want to keep the premiums down, because it's very simple. It suits some of the doctors because they learn how to do these fancy medicals that you get paid $1 squillion for, but it's an absolute travesty for the poor bastards who are injured. And I think the AMA guidelines are one of the most pernicious things that I have ever seen. And when I was in Parliament, I spoke against them, and the union said, oh no, we're getting very good doctors, specialised doctors to evaluate people. And it went through by the Labor Party, supported by the unions, for God's sake, an appalling travesty of justice. And I agree that it's difficult to evaluate people's condition as to how crook they are, but you've got to do better than the guidelines that are a complete farce. Now, in terms of over-servicing, I don't believe patients generally want more medicine. They want good treatment. They don't want more medicine for the sake of having more medicine. If you said to them, look, I should do this because it'll help you, they'll take your advice 99 times out of 100, because they'll say they think that you have goodwill towards them, right? And so you should. In terms of over-servicing, there are doctors who will do more treatments than are needed. I think that is a fact. It's an unfortunate fact, but it is a fact. If doctors have a shortage of work, they're more likely to do that than if they're working to capacity, where there's no incentive to over-service. But the main drivers of over-servicing, I believe, is fear of litigation, so that you, rather than use your judgment, you say, well, I'll do a test. But the most significant driver of over-servicing is the technology companies. And I discovered this. I went back to I've been doing a bit of revision lately, professional revision stuff. And I worked in the ED departments for a while. And they kept asking to do hundreds of different tests, and I said, we don't need that, we don't need that, we don't need that. Oh, we do good medicine here, doctor. And I said, what are you talking about? But what happened is, all these are done with trials of protocols. In other words, if you have a headache, for example, you have this protocol. And the protocol is worked out in a series of American teaching hospitals, which have every possible test you could ever do. And they put these people through and give them every possible test they could have, and then say this test is valuable, this test is not valuable, So it assumes that you're in a worst case scenario and will be diagnosed. And so effectively the treatment protocol for a headache becomes all these different things, right? A head scan, a thing, and so on. All these tests are done for the smallest symptoms. So effectively all the people who just had a headache and needed an Aspro get this protocol. And then if you don't do the protocol, either you didn't know the protocol, naughty doctor, or you were too lazy to do it, naughty doctor. So effectively the pressure is on, and of course if anything goes wrong later and you haven't done the protocol, liable doctor. So effectively this, and of course when the technology companies and the blood pathology companies and the radiology companies and the whole lot all provide freebies for these teaching hospitals in America, which then produce the study in the world in the most prestigious medical journal, you can't stop this sort of economic juggernaut. Now my view is take it back to the doctor and let him or her make the decision would be better. But there is an over-servicing drive which is financial for the doctors but also is driven by this fear. I don't think patients generally, they generally take your advice, right? So in a sense the services are generated by the doctor. Sorry.
No, that's right. Just in relation to, probably come to some of the same material with regards to bullying in particular, from an insurer's perspective, and Dr. Chesterfield Evans and I were just talking about the fact that when you bring a litigation case against an insurer, you're effectively giving the insurance company some permission to basically look into your medical history. But what we're finding, and Dr. Chesterfield is in the practice of medicine, is that insurance companies, all you're given permission to do is to request your clinical notes and speak to your doctor. What they're actually doing, or they're embarking upon when you're saying bullying, they're actually embarking on this process of intimidation of respective doctors. You've effectively got doctors akin to sole practitioners. They operate in their own single individuality for the benefit of their patients, up against a massive insurance arm. And you've got these rehabilitation providers who basically impose themselves on the consultation. So they'll come along with the injured individual and say, I want to go in there and see your doctor with you. And a fundamental right is the patient can turn around and say no. And the doctor can turn around and say, no, I don't want to talk to you unless I've got the authority of the patient. But the insurer, they're getting better and better and better at imposing themselves and bullying the doctors into making people go back to work earlier, because we've got this rehabilitation, get them back to work. Everyone does want to get back to work, but getting someone back to work before their time or before they're healthy enough to do it is counterproductive, because it's not only that they can't physically do it, but when they get back to work, they're not as productive as they once were. Their colleagues and their managers and their performance suffers, and as a result they could effectively lose their jobs. And they effectively are not seen as pulling their weight and contributing their fair share, because they're being cleared to go back to work by their doctors, who are unfortunately being bullied by these rehabilitation providers. So it happens. With regards to the table of names, it has been superseded by the American AMA guides. My biggest concern is, and I'm not too sure why it's happened, and you can probably enlighten me, there's an AMA 6th guide now, or 7th guide. So there's different versions of the guides, and the guides have been superseded by, I would hope, a more improved version. But if you believe that the New South Wales government had any genuine intent of compensating people for their injuries, with the CTP, the compulsory third party scheme, they're still using the AMA 4 guide. So we're sort of 2 or 3 guides past that. So a more improved version. They're still insisting upon using the AMA 4 guide. The workers' compensation scheme in New South Wales is using the AMA 5 guide. So even they're behind the 8 ball, but they're a lot better improved. Now, when it's always been met with resistance to bring up the AMA 4 to the AMA 5, because it's, in their view, a lot easier to get over the AMA 5 threshold of 15% whole person impairment than it is to get the 10% whole person impairment threshold in the AMA 4. That's effectively what happens in that regards. Just with regards to over-servicing, when we talk about over-servicing, it's similar to fraudulent claimants. I would put it in perspective as to how often does it really occur in the grand scheme of things. I wouldn't say it occurs that much in consideration to for the amount of doctors out there and the amount of consultations that happen per day. I would say it's such an insignificant amount, which doesn't need wide-rafting reform. So it's effectively throwing the baby up with the bathwater when you're dealing with those sort of issues. They need to be dealt with on their own merits.
If I could just make one more comment on fitness to work. What happens is the rehab people take somebody and say, we'll assess your fitness for work. So a pretty girl says to the guy, they're mostly blokes getting injured, they're mostly girls doing rehab, right? Not all, but let's take a general case. And of course they try as hard as they can to please the rehab person. They do the tasks for an hour or whatever it is, and then of course it's assumed that they can do that all day, every day, 35 hours a week. And then of course if they can't find a job for them, or you make a restriction, they then say, oh, they're not completely impaired, they're only a little bit impaired, so we only have to pay them a little bit of compensation, get it? So effectively you're bullied into saying, well, what can they do? They're not completely bedridden, are they? They must be able to do something. And as soon as you say, yes, they can do something, oh, well, they can have this compensation then. Even if there's no chance of them ever finding a job. So it's very Kafkaesque, really. Yeah. And I don't know what to do about that. It's a difficult question and I face all the time.
Yep.
John Inshaw. So far the discussion has been in regard to getting people back to work after one of these mishaps. What happens to an older person, say in the 80s, whose quality of life is probably destroyed because of a mishap? Are they entitled to any compensation?
It depends on the level of injury. You're still subjected to the AMA guides. So if it was as a result of a motor vehicle accident, then you'd be restricted to the AMA 4 guide. The concern I have about the legislative review, and as Dr. Chesterfield-Evans stated, it doesn't assess disability. It's purely around impairment. So the impairment test for a shoulder is literally your rotation of movement, forward, back, not concerned about your pain, how high can you lift your arm, how high can. And we have some patients who've got better days than others as to being able to lift their arm. So it's pretty much on the day of assessment is effectively what you're assessed by. The C2P scheme is saying that there's a concern about the low injured claimants, the low injuries. But the greater majority of all claims are people who are moderately injured. Now there's no allowance for that at all. It's either the most serious injured, which is over 10% whole person, and it's not an easy threshold. Of 100 claims we see, only 10% to 15% get over that threshold. So depending on your level of injury, 90% of the time you're not going to receive anything for pain and suffering because you'll be excluded by way of legislation on the AMA Guides assessment.
My name is Peter Murphy. I'm on the Politics and the Pub Committee. I just wanted to ask about the legislative timetable. You're talking about changes to the CTP. What's happening in the New South Wales Parliament on that? Have we got some committee discussing it for a while? Is it 3 months or 6 months? What's happening?
Our view is that a number of submissions have been tabled by relevant stakeholders, and as a result they've had 4 individual options. Options 1 and 2 were effectively not too much change. There's some process changes which would have improved the process in our view and not diluted people's rights. Option 3 is the more significant, which removes, which takes it to a completely no-fault scheme. What we've been told is that 1 July 2017 is effectively when it's likely to come in. So it'll be discussed in the September sittings, and then our belief is that 1 July 2017 is effectively when it may come in.
I would say that it's that write to your MP now and write to the Minister now would be the best advice I could give on that.